Yeah, actually, my task has become very difficult after speaking after Dr. Bari, because his experience, and actually we follow him also because he has such a wide experience that I've learned so much from Dr. Bari. And recently I had visited Russia also, Bangladesh, so I could see so much of variety. And Ilizarov is a learning thing. I've learned so many new things and I've changed my techniques also. So I work in this hospital. This is Gangaram Hospital. It is in New Delhi. Now, I have to acknowledge a few books which I have consulted, and also I've consulted Dr. Bari's book. So this is the last one, is the Color Atlas of Limb Lengthening, which I have consulted. I have consulted all the standard textbooks. So before we go and understand, because Dr. Bari has explained you about the infected non-union, but there is something known as aseptic non-union. So let us now first learn about principles, how to manage them. There are some differences which will go. So we have to go to theory first, and then I show you the cases. Now, first definition Dr. Bari has already given, and non-union is established when a minimum of 9 months have been elapsed since fracture shows no visible progress signs of healing. So this Dr. Bari has already told you, and this you also say delayed union if it is less than 5 months, and Federal Drug Administration panel has given this definition. Now there is one term known as aseptic non-union. A non-union without infection is aseptic non-union. And what is zoodarthrosis? Because this term comes very often, and it's a non-anatomical joint formed between two fracture ends with a synovial fluid. So these are the definitions which come very frequently in when we describe about non-union. So Dr. Bari has actually shown this slide and he has explained about everything. But I want to make a point that, it is not the bone which is important. It is the soft tissue also, which has to be given due consideration. So inviable soft tissue, bad skin, and the tissue between the bone ends, inadequate local blood flow, infections, or Dr. Bari has already talked, muscle atrophy. Muscle is very important. So you have to give due diligence to every part. Joint stiffness. If you are treating a case of non-union and your joints, adjacent joint become stiff, then your purpose is not there. So purpose is defeated. So arrest of callus formation, bone defects, extremity shortness, osteoporotic bones, deformity, and malalignment. So Dr. Bari has already explained this thing. So with this, then we move forward. Now there are different classifications which cause a lot of confusion. So let me go to the widely accepted classification, because every classification has a message. So classification basically have academic value, but let us go through what is there in the literature. So for very widely accepted classification is Weber and Czech classification, which was given in 1973, and he has explained. He has divided arthrosis into two types: hypertrophic and atrophic. So hypertrophic, he has given three types. This is one is the elephant foot, where the bone end at the fracture non-union side becomes thickened. The diameter is more than the normal bone, and it is rich in callus. It occurs when there is inadequate fixation, premature weight bearing, but there is a viable tissue, the viable fibrocartilage, and there is a pseudo joint formation. So the treatment differs in all different types of aseptic non-union. The second type is horse hoof, which is basically a smaller version of elephant foot. It has a poor callus, failed or unstable osteosynthesis with plate and screw gives this type of horse hoof type of variety. So with plate and screws, it has a silent callus which never transforms into fixed callus. So this part never transfers, unlike the hypertrophic non-union, which is a viable callus. This is a dead callus. There is another type of hypertrophic type, pseudarthrosis, which is known as oligotrophic, and this is basically no callus formation. And there is if you stabilize with a plate and screw and you leave some gap, this type of situation occurs. So when the fracture is not very much compressed at the fracture site with the internal fixation, you get this variety. Now we come to atrophic pseudarthrosis, which has four types. One is the torsion, fragmented, defected pseudarthrosis, and atrophic pseudarthrosis. So in torsion wedge type, we encounter this thing in many cases where there is a butterfly fragment. So blood flow is affected in the intermediate fragment, and no stable bridging, and fixation by plate and screw can cause it. Like this can, plate and screw, if you do not give a proper stability to this fragment, so it can go into non-union. And if this is a displaced, the fragment, the extra fragment, the third fragment, and it is due to the increased combination, and it, increases the risk of non-union. Plates can be broken due to overloading if weight bearing is started early. So if the fixation is not, the healing is not occur, and patient does an early weight bearing, you have this variety, and it fails, and there is no callus formation, and there is a defected zoodarthros, and there is a gap, and there is a absence of part of the diaphysis seen in tumor, infection, bone resection surgery, and it will transform ultimately into atrophic non-union. This is the atrophic zoodarthros. This is the worst type. This is the worst type, and it has osteoporosis and atrophy of the fracture site. There is a shortening of greater than 2 centimeters, and stabilization with biological stimulation is required to treat this type of non-union. Now, Professor Ilizarov had given his classification. This is the first classification, and this is the loose type and stiff type. So movement and angulation is more than 7 degrees at zoodarthrosis site, and shortness of more than 2 centimeters. Atrophic look on X-rays. Biological stimulation required with stabilization means you have to compress the fracture site and also do corticotomy to stimulate the bone. So the loose type, the treatment pattern is different. Now the stiff type, the movement of angulation is less than 7 degrees at the zoodarthrosis site, and shortness is less than 2 centimeters. This is basically the hypertrophic or the elephant foot. So compression and distraction force at the fracture site will cause healing, because at the hypertrophic, the elephant foot type, which I have already told you, there is a viable callus, there is a viable fibrocartilage. So you compress first, crush the non-union, and then start distracting it. It will go into healing. You don't require any bone graft or anything to do extra for that. Now, Pele has given his classification. It's basically the same type. Just to complete it, I'm showing this thing. And zoodarthrosis is less than 1 centimeter bone loss, and he has categorized into A1 and A2 types. One is the loose type, and one is the stiff type. And was the stiff type, one without deformity and with deformity. There is another type of zoodarthrosis where there is a gap, and he has divided into 3 types. Bone defect in all of them, whether there is a shortening or there is no shortening. Now coming to Katani classification, which I follow because it gives what to do in a treatment. So he has basically, you have to understand that non-unions are 2 types, either lax or stiff, and stiff can be with the deformity or without deformity. So classification based on clinical and mechanical properties rather than radiographic appearance, it helps in determining the type of operative intervention. Means the classifications have academic value, but you should know what you have to do, which method of treatment with Ilizarov you have to do it. So that basically should be in your mind. Ultimately, you have to give the result. Now, coming to lax non-union. So for your practical purpose for surgery, lax and stiff. So we first come to the lax non-union. This is the atrophic type. This has a less inherent mechanical stability, radiological, avascular, poor callus formation, and minimal surface contact. Tissue between the non-union is amorphous, fibrous material, and little potential for bone repair. And instability and lack of vascularity causes it, and loss of vascularity is also caused by infection. So this is my very old patient in 2004, which I treated. You can see the atrophic bone ends, and he was walking on a Thomas splint for almost 4 years. So this will never unite. So stiff type, there is exuberant callus, large area of contact. Tissue at the non-union side is fibrocartilage, capable of bony metabolism and bone formation with compression. So you have to compress, crush the non-union, and then you go in for distraction. Instability of fracture site is the cause. If you are gone to treatment, the area is unstable, it can go into hypertrophic. And Ilizarov research demonstrated that compression distraction force provide mechanical stimulus for bone formation. Now, biomechanical principles of treatment. Stiff non-union, you have to do a continuous compression, stable compression without bone graft or corticotomy. You don't require any bone grafting. Just if you give a compression, continuous compression, as Professor Ilizarov, this is Professor Ilizarov's word, and this is monofocal intervention at the fracture site. When you are only, concerned about the fracture site, this is the monofocal, the definition of monofocal. Now, lax non-union, you have to give a stable fixation with biological stimulation also, means this is bifocal. Once you are doing at the fracture site compression, or also distracting at the corticotomy site, so you increase the vascularity. So this is the treatment where there is no deformity in the bone, but you have a stiff non-union and a lax non-union. Now, what are the indirect reduction methods? So stiff non-union, you can distract this thing. This is the stiff hypertrophic type. You can put a hinge, and you can, if you distract it, it will go into union. Now, if you can just, these are with plain wires, you can use olive wires like 3-point fixation, 2 olive wires at the end and from this side and 2 from this to pull the fragment, and you can apply a hinge and distract it. Now, stiff non-union correction by olive wire alone. So this is the olive wire alone compression. You can do it in this way. Means you are not basically applying the hinge. You can basically do it. You pull the fragments. If the non-union is not very stiff, so you can pull it. You don't apply hinges. You can put 2 stiff pins, and you can put it. You can have a distraction mechanism here, and you can correct this deformity in this way. Now, if there is a, there is a translation, so you can have an assembly like this, and you can pull both the fragments towards each other. So this is a translation type and how to treat that. This is the oblique compression type, means you have to compress it. So you put the hinge at the neutral hinge and just distract it, so the bone will reduce and non-union will get treated. These are all basically not the atrophic type. These are basically the type where there is, you feel that the bone ends are viable. This is the oblique distraction type. If the fracture is oblique, you can have an assembly like this, and you can just distract it, and you can treat the non-union. There is no requirement in these cases for bone grafting or any corticotomy if you feel the bone ends are viable. Now, if coming to the bone loss, Katani has given bone loss with limb shortening, without limb shortening. So you just compress it. Shortening with fragment, what you do that you do the compression and do the corticotomy, and shortening with segment with a bone gap and no contact of bone. So you can do the transport. So treatment of bone loss without shortening is a bifocal transport. Dr. Bari has beautifully explained about it. So you do 1 corticotomy and compression at fracture site and 1 corticotomy. It is known as bifocal transport. So this is animation. It works on best works on a single rod, and you just the rings at the end are fixed rings, and this ring is mobile. So you can transport a fragment. Similarly, you can what you can do that you can do the compression at fracture site, and you can distract it at other levels. So the assembly is different. It does not work on a single rod. It's better to have 2 different units. Now, trifocal transport. If you have 2 types of corticotomies, 2 sets of corticotomies, and then the fracture site, so it becomes trifocal. One side is compression, is the monofocal, then bifocal, and then trifocal. So these 3, and you are working at 3 sites, it is a trifocal. So this is a trifocal transport. You have corticotomy is at 2 levels. Now there is another technique where you use the crossed olive wires, and which acts like a rein of the horse to direct the bone. So you pull it with the olive wires. Now, frame application technique, shortening with bone contact, bifocal frame can be used, shortening with bone gap, trifocal method can be used. Now, there is a concept, sometimes in literature, you will find internal lengthening and external lengthening. So what is the definition of internal lengthening? regeneration of bone to fill the gap without change in overall length in the limb. Like there is a stiff hypertrophic non-union, you first compress and you distract. So that is basically, if you want lengthening, it is the internal lengthening. External lengthening is to regeneration to restore the limb length and soft tissues. Basically, there is a gap non-union and you do the transport and then you lengthen it. So it is known as external lengthening. So there is I use this technique. This is a chipping technique with Mashuta Takashi has, basically described this thing where in a stiff non-union, you can just make a small incision and, do the chipping of the bone around the non-union with a small osteotome. So in this, I do it in certain situations and you don't require bone graft. So we will also see in the cases. Now, case 1. This is a 37-year-old female, sustained fracture of lower tibia and fibula. Plating of lower end of fibula and metaphyseal plate in tibia was applied, and patient went into non-union with implant breakage. Removal of plate and excision of non-union, proximal corticotomy and Ilizarov fixator was applied. Now see the situation. There are 2 plates applied, and I took the history of the patient. It was a well-fixed thing, but the problem was that there was some gap at the surgeon could not compress it. And I asked the patient gave a history that I started early weight bearing against the medical advice. So this was her situation. There was no infection. So what I did, I excised the non-union. I stabilized the fibula with a intramedullary wire. Dr. Bari has shown this thing in upper limb, but it is very useful. You can put an intramedullary wire in the fibula. And then it is better to excise the non-union. I excised it because it was a atrophic type. And I did a proximal, it requires bone stimulation. So I did a proximal corticotomy and did a bifocal transport. So this is this thing. And it went into union with the transport. And you can see the union. And she is fine. We can see a video also. So this is basically, I took 5 months to remove the fixator. You can see her walk. So you have to see that if you are doing internal fixation, your fracture end should have a compression. You should, also explain the patient carefully that when he should walk, and you should explain the patient that unless you tell them, they should not start walking. Now, case number 2, this is 22-year-old sustained fractured distal tibia and fibula. Close internock nailing was done. Fracture goes into non-union. Then surgeon, what he does that he keeps the nail inside and then he reinforces it with a plate and did a bone grafting. Fracture still failed to unite and it was referred to me. I did the removal implant. Ilizarov fixator was applied with compression of fracture site and it went into non-union. So this is a young boy and you see that first he did a nail and then it went into non-union and then he reinforced it with a plate and then put a bone graft. Now the issue is that if your mechanics at the fracture sites are not good, it will again go into non-union. So it was a very good fixation, but it went into non-union. So what I did that I just removed everything and just did a continuous compression at the fracture site, like what Professor Ilizarov has told. I was planning that I will see what happens with continuous compression and I might have to stimulate. If it does not work, I'll do a proximal corticotomy and some distraction. But limb length were equal. But to my, surprise, which I was thinking that I will do corticotomy, it went into union. So this is the situation. This is the patient with the frame. You can see his knee bending. And you can see his now. It is after removal of frame. See how well he's walking. So the message is that if you are doing internal fixation, it is very easy to apply, put a plate or apply a nail, but you have to follow the biology. You have to respect the biology so that these complications don't happen. Now coming to case 3, this is a 50-year-old man with comminuted fracture, gustilo grade 2. So this gentleman had a very comminuted fracture and he had a small wound and he was treated with plaster and dressing. At 2 weeks, the infection healed, but the fracture was so much comminuted that the surgeon put him in a plaster for 4 months and he did not know what to do. So he was referred to me and now this was the situation. There was no infection and you see the multiple pieces lying and it is very difficult to fix this with a plate, and because if you go inside you will all devitalize these fragments. So situation when I removed the plaster, there was a kind of a deep dermal area of defect, but there was no infection at all. So this thing is the same wound, which is basically a deep full thickness. So I took a plastic surgery opinion. They say that just leave it. It will go by on its own. We don't have to require to do any plastic surgery procedure. There was no infection. So what I did that instead of basically touching these fragments, I just left the gap and I did a proximal corticotomy and started transporting. Now the mistake which I did, I transported in LRS. I should have put a Ilizarov and I could have used for the transport a spatial correction, but I just transported it. The fracture united, all these fragments, they acted like graft and they became a solid union. But the patient had a residual valgus deformity. So I told him that, I will correct it because I used an implant which was a monolateral. I could not correct the deformity. But patient says, no, no, sir, I am very happy because I was not walking. I used to walk on plaster. So he is happy. He does not want the correction which I have told him that I will correct your valgus, but he does not want it. So I did not touch the comminuted fragments and I just did a corticotomy and transported it. So this is this, X-ray after 1 year. You can see this thing. Case number 4, this is a 20-year-old patient, had a subtrochanteric fracture and it was treated at the age of 10 years with traction. So this was old. So when it was treated, he again had a refracture and he was referred to me somewhere 10 to 12 years back. So I applied LRS and I did not do any corticotomy, but the patient's parent and the patient did not tolerate the orthofix and they forced me to remove it early. So the LRS was removed. It on the X-ray I felt that it is united, but it was not a proper this thing, and he developed into stiff hypertrophic non-union. Then he came after to me, and then I applied Ilizarov, did a distal corticotomy, and the hypertrophic non-union went into union with compression and limb and distraction, and I sorted out the limb length discrepancy, and he came to me almost after 6 years. So this was the situation. He had he was treated in the childhood by traction. Then he had a fracture. Then I applied this thing and I felt that this is united and they forced me to remove it early. Then it went into hypertrophic non-union. You can see this is elephant foot type. This was the situation. I applied Ilizarov, gradual compression and then distraction. Did not bone graft this area. Did a distal corticotomy for limb length discrepancy and it increased circulation and went into union. Now this boy comes to me after 7 years. This is the situation. We can't make out also that he had 3 times he had surgery. Now, case number 5, this is a 5-year-old boy who came to me with deformity right ankle. He sustained a run over by a motorbike wheel, had stiff non-union just distal to the distal tibial epiphysis. Non-union was freshened by the same Japanese chipping technique. I made a small incision and just distracted it with the hinges. So this was the situation. And I just, because it was so near the epiphysis, I just opened from here and just did the chipping and distracted it, and it went into union. Now coming to case 6, this is a 23-year-old motorbike accident, had a segmental fracture tibia, initially treated with plaster, then plating was done. Developed hypertrophic non-union at lower side, chipping of non-union site, and proximal corticotomy and LRS orthofix application was done in 2017. So this boy, he is a medical student, had a fracture, upper part, and this was a segmental fracture. So there was a union at the upper part, but this was a non-union, which was basically he used to not be able to walk full wear weight, and he could not run, but he was walking. So what I did is that I did the chipping technique. I chipped this whole thing. You can see I've done the chipping here. I did a proximal corticotomy. And you can see I did, distraction was done for limb and this. And now this boy comes to me after 7 years. This is the situation. I just took this X-ray of, almost, um, you can say after 7 years. So this is basically the fibula is distracted because of the lengthening. This is his, when LRS was there. Now he has come to me again and he's fine. Now, this is a case 7, a non-union distal tibia fracture after failed internal fixation, excision of non-union and bone transport was done. Now, this 51-year-old overweight woman sustained closed fracture lower third tibia and fibula. She was crossing the road and had a run over by motorbike. Internal fixation first was done by anterior lateral plate and later reinforced by small locking plate. Went into non-union and referred to me for Ilizarov Fixator. Now this you can see is a very benign looking fracture which we encounter in ours. So just putting internal fixation with 2 plates could have done this thing. But what happened? Surgeon just applied the anterior lateral plate. He did not address the fibula. So what happened that it went into non-union. So patient came to him. So what he did that he did fiblectomy here, and again put the screws, retained the same plate, and put a extra plate on the medial side so that he has reinforced. But again, it went into non-union. So for me, the option was to excise, move everything, excise everything. Did a proximal corticotomy, applies the Ilizarov frame. This is the patient with the frame, and this is the proximal corticotomy. See, the fracture went into union, and this is her X-ray. Now coming to case 8, this is a 43-year-old male, had a fracture lower third humerus with a butterfly fragment. Dual plating was done, fracture went into non-union, and later breakage of both plates. Basically, the history is that everything was fine, and he had a fall. But he did not take an X-ray and continued. But what he realized that after 1.5 months, the elbow started having the deformity. So patient was referred to me. I removed both the plates and Ilizarov was applied and healed with compression with the fracture site. This was his first X-ray. You can see 2 plates. So much of metal work was done. I think they have totally removed all the periosteum was elevated, and you can see it was already a non-union. Then he had a fall. The patient plate started bending. So I removed everything, just compressed at the fracture site. And you can see this is the frame. And you see the union. This is the X-ray of the day when I remove the frame. It's after removal of frame immediately. Now his elbow movements have improved and have become almost normal. This is the day of I removed the frame. Now, case number 9, this is a 30-year-old male, had a landmine blast injury with injury in the both lower limbs. He is from Afghanistan. So he had multiple surgeries and multiple flaps, and he came to me. Now this was situation. Now problem with me is that this is a split skin graft. I could not open, and no open surgery could have been done. So he used to walk like this. So they referred to me. What I did that I just, because the fracture, the non-union are very near to the ankle, I just did the chipping here and just distracted it with the SUV frame, and it went into union. This is the situation. So thank you very much. And my cases I think are less in number than Dr. Bari because he has a very wide experience. But yes, today the talk, I think you all would have an understanding that what is the modality and how we apply Ilizarov in aseptic non-union and how in infected non-union. So aseptic non-union usually you find with failed internal fixation. Thank you very much.